So welcome everyone. I am Diana Londoño. If you don't know me, of course, I'm so happy that you're here. I am the founder of physiciancoachsupport.com, which is a free and confidential platform for all physicians to come in to and get support by a peer who is a physician, who's a volunteer, and they're also certified life coaches. So you can come in with anything that is on your mind. Maybe you're having a hard day, you're have a meeting coming up, you're feeling like an imposter, you're just feeling tired, you just don't know what your next step could be. We could just really help with really anything that may be challenging you, and just give you a different perspective and give you just, again, peer-led support. So that's who we are. That's we're about really giving you hope, giving you a way out of burnout, because many of us are there, have been there. I've definitely have been there twice. And it's not to say that these are my scars to prove something, but to just say there is a better way, and there is, a way to get out of it. So today we're really focusing on women's health, and we really want to talk about, half of the world's population, right? So this month, it was perfectly timed that it's Menopause Awareness Month. And so this is just really important because it's going to affect so many women in the world. So Dr. Victoria Sorlie-Aguilar is my good friend. She is a physician, a family physician in Ventura, California. She is USC and UCSF trained. And, she really started to get interested in this. So she's going to tell us all about it during her own transition during menopause. So she's really going to give us some up-to-date information, kind of tell us things that we don't all know about, whether it's for you, for your aunt, for your patient, really ways that we can really help ourselves, others, and patients, and to really live joyful lives in this transition, really reclaim that, feminine goddess and our femininity, and really just thrive and not, wither down and, fall like a little wilted flower. So again, we're so excited. Please welcome her here, and really tell us, because you're family, so you could have chosen diabetes or like dead feet or something else to really get excited about, but you did. We're really excited about bringing this transition, just like joy and information. And really, you are the only person, because I'm a urologist and I actually don't treat a lot of women. I treat mostly men by preference, but I really got excited about talking about this, sharing this information, and really treating women who are suffering with dry vaginas, recurrent infections. We'll talk all about all this, and you really got me excited. And so this is like, this is what I do for you. Just get you excited.
Success.
After 15 years, I was like, oh no, I don't want to do the vaginas, but I'm really actually excited about this because of your voice and your being. So welcome, and tell us how you really got started. I really touched on it, but tell us really how this happened for you.
Well, first of all, thank you so much. Thank you so much for having me on your platform. Thank you for the work that you do with physician coach support. So important to support fellow healers. And boy, I can't think of anything that makes my day more than you saying you got excited about vaginas as a urologist. Yes, that's so exciting. And so yes, I'm a family doctor. I went trained at med school at University of Southern California, USC. Trojans, go Trojans!
UCLA.
And then
Okay.
yes, I did. I know you said that's okay. My daughter goes to UCLA, so we're
Okay.
equal. We're a split household. So and then I did my residency, family and community medicine at UCSF Fresno in a rural teaching facility in Fresno. So I have a broad background, sort of broad family medicine, and I've been practicing. I graduated from med school in 2003, so almost 20 years ago.
Wow.
And have been practicing sort of community-based full spectrum family medicine for the last 20 years through residency and then after. And really appreciated treating the whole family, the whole person, the whole woman and man, and just all comers. And then a few years ago, I went through menopause transition myself. And in my mind, I thought, wow, this is way too early. I'm not even 50 yet. Something's not right here. And I sort of started asking around to friends and colleagues, what do we do? It just hit me by surprise. It happened for me around 45, 46. So I knew about menopause. I knew it would come someday, but it came way sooner than I was prepared for. In the back of my mind, I was like, someday I need to figure that out. So when I get there, and then it hit me, and I was sort of in the maelstrom of the symptoms without knowing that it was menopause. And we can talk, I want to talk about that because so many of the symptoms that I was feeling are just classic for menopause, but in my mind, I wasn't associating them with menopause. I just thought something was going crazy there, crazy wrong with me.
Well, this
And
is a
so,
great thing because I think many people, I mean, the thing that I think about, whether I was younger, not a doctor, or as a doctor, like we just think like these hot flashes, like, oh, you must get hot flashes. And then some even
mm,
women do, some women don't. But
yes.
first, I guess, like for those that are not physicians, and even if you are, just to recap in case you're, a pediatrician, what is the definition of menopause? Like, how do you know you're in menopause? Like, what's the book definition? What's happening for you to say, I'm in menopause now?
So it's a little nuanced, but the most straightforward way of answering that, the thing that everyone will agree on is if it's been a year since your last menstrual period,
Mhm.
your final menstrual period, they call it FMP, final menstrual
Oh,
period, the
I know.
final one, the final countdown. If it's been a year, you're in menopause.
Got it. Got it. And so
Um,
another important thing too is when women bleed after that 12-month period of no periods, right? That is never normal. And that
not
definitely needs
normal.
evaluation. So please,
Yes,
if you are bleeding and you have not had a period for a year, you need to see your doctor right away because that needs evaluation. So I want to make
absolutely.
sure that people don't say, oh, yeah, well, just a little spotting. No, no, no. You need to go see a doctor. But okay, so
And
you
it
have the
kind of
12
becomes
months.
important, like just because of what you said, to start tracking it. I know when
Mhm.
we're younger and we're like maybe just started our periods, we might track it, or if we're in our fertile years and we're trying to get pregnant, we might track when we ovulate. But later you just sort of forget to think about it. It comes when it comes. But in that transitional time, so like the standard age of menopause is 52, average
Mhm.
52. But the
Mhm.
normal range is anywhere from 45 to 55. So where I thought, wow, this isn't normal, totally within the normal range. And even as a doctor, I didn't know that. And if I would have known, then I would have started tracking it like, oh, it's been a year. This is normal. This is exactly what's supposed to happen. I would have been more prepared. So if women know that it's normal anywhere from 45 to 55, and if they sort of track it and it's been a year, they're like, okay, this is menopause. And the symptoms, like you said, it doesn't have to be hot flashes. It is often hot flashes and night sweats and the insomnia that goes along with that and the fatigue that goes along with that. But it's also other stuff too, vaginal dryness, repeated urinary tract infections, the urge to urinate all the time, frequency, urgency, sneeze and pee, that kind of stuff. Totally not sexy, but just women just might take it for granted, like, oh, that's part of aging. That's just what happens. But it
Mhm.
doesn't have to be the normal part of aging to put up with, sneeze and pee. I know that's your forte in urology circles, but things like that. And then also other things, symptoms of menopause that are really, really common and just it's known is weight gain, fatigue, palpitations. A lot of women in the range of 45 to 55 go to the doctor with palpitations and they get like $1 million workup cardiac, which, yeah, I mean, it makes sense. But in the end, they get told you're fine. You're
Mhm.
fine. But
Mhm.
they're actually, it's their menopause that's giving them palpitations. And it's just an unrecognized symptom of it. And anxiety and depression and low confidence and low self-esteem, a lot of that stuff is just directly related to that lack of estrogen and the impact that it has on our body. And if we know that, if we recognize those as symptoms of menopause, then we can be more likely to go and seek help from our doctors.
Yeah, that's really important because, we don't think about the psychosocial, the psychological aspects of menopause that are definitely, part of it because the estrogen, there's a change in the hormones, and hormones are really powerful,
Yes.
and the neurotransmitters and the hormones that, our ovaries are secreting. So now when you're like to zero, 100 to zero, now you're gonna get everything affected, including like the skin, like dryness too,
Yeah.
not just the vaginal tissue,
Hair
but
loss, hair loss.
hair
That's a big
loss. Yeah.
one.
So you start having these different changes. And again, you know, many people are led to believe like, well, you just deal with it. It's just whatever, and just kind of bear through it and see what happens. And, like, so be it. But
Yeah.
that doesn't have to be really, what happens. And I also kind of want to point out, because we're kind of talking as like everybody, all comers, but I mean, what is the impact? Just kind of get a little bit of the numbers of like how many people are impacted by this, and also like touch a little bit on Latinas, or like the more underrepresented, because it's very different for different groups.
Yeah.
And I can say that
Yeah.
even for like cancer screening and outcomes and everything, it's not the same. So tell us a little bit more about really numbers so people can see the impact of how this affects women, and who's getting treatment, who's not,
Yeah.
because we may not know even what's happening, but who's even getting some treatment for this.
Yeah, so like you mentioned in the flyer, 1 billion women in the US in menopause or going through menopause, or in not in the US, in the world, 1 billion women have gone through menopause or are in menopause. 50 million women in the US are going through or are already menopausal. So huge numbers of women. But if you think about it, half of the whole world's population, if they live beyond 55, will absolutely be in menopause. Like it's inevitable for everyone because eventually our ovaries stop producing estrogen. So like half the world's population will eventually be in menopause if we survive and are healthy enough to get there. So it's so important. And I feel like for something that's going to happen to half the world's population, it's just not talked about enough. And we're underprepared for it. Like we need a license to drive a car. We get told to carry around a pad for our first period, but no one kind of tells us like, okay, a bunch of crazy stuff is going to happen to you when you hit 50. So I think that's why it's so important, because it's so widespread. It's half the population, and also because the symptoms can impact, like you said, emotional, physical, social, so many aspects of our life. And before, say, even 20 years ago, before I went to med school in the 90s and 80s, well, I went to med school in the late 90s, but before I was a doctor, a lot of women were on menopausal hormone treatment. It was sort of standard when a woman hit 50. There's a
So,
dog barking across the street.
okay, I was like, that's
When
okay.
a woman hit 50, she would be put on sort of automatically, here's a prescription for menopause hormone therapy. Good luck. You're going to have a great ride. It's going to be wonderful. And it was sort of the standard of care. But in the early 2000, like 2002, there was a huge shift, and everyone was taken off of their hormones. And that's when I was trained in med school. And it was sort of like, don't use hormones. They're not safe. Don't put women on them. It's not worth the risk. And so many women from that moment up until now have been underserved in terms of their menopause care. And so in the early 80s and 90s, 50% of menopausal women were treated with hormones. Right now, in 2022, less than 10% of women are treated with menopausal hormone therapy, and less than 5% in the US, I'm saying, but it's sort of like global, but less than 5% of women in the US are on FDA approved hormone therapy. So the numbers are really, really low, 50% in the 80s to 5% now, which means 95% of women having symptoms are not getting treatment, which is huge. I mean, that's
Yeah,
huge.
I mean,
And if you're an underserved population, a minority population, either economically or by ethnicity, then of course underserved in any aspect, even more underserved, and especially if there's a language gap. It is hard enough for a woman who speaks English, who knows to get treatment. It is even harder for someone who is not a doctor, not in the medical field, to get treatment, and even harder if there's a language barrier. So it's hard enough if you speak English and you have some understanding. It's near impossible if you don't have an understanding and there's a language gap. And I think that's why so many women are underserved. And it's not just a matter of like, oh, you're going to have hot flashes, whatever, suck it up, woman. I mean, that's sort of the message we get, but it's way more critical than that, because hot flash is just a symptom. But that is not representative of all the changes that the physical changes, permanent changes that happen in our body when we live in a low estrogen state. Huge changes happen, and hot flash is just a symptom. But
so tell them, I mean, because, that study, is like the like nurse study, they took everybody off because, can you tell us what happened in that study for those that don't know about it, and why everybody got pulled off of their estrogen? What did they find there? And then what is the new sort of statement? I know you kind of follow like the
North Atlantic Menopause Society.
Yeah,
Yeah.
the North Atlantic Menopause Society, which I just learned about. And you follow these new guidelines. So it's very different than what happened in that study. So can you kind of briefly, and I mean, you don't have to get too technical, but what was it, the reason that everybody got pulled off, and what's happening now? What are we saying now in the guidelines? But then also, when should somebody come and talk to their doctor and say, what should I do with my symptoms? But maybe we should start there, actually. Like, when should somebody start talking to their doctor about anything, like whether it's a hot flash, peeing too much, infections? When should we talk to the doctor?
Good question. So definitely, if it's been a year since the final menstrual period and the woman's having hot flashes or night sweats or can't sleep or chronically fatigued or feeling more depressed, definitely vaginal dryness, frequent urinary tract infections. I mean, in an ideal world, when a woman goes in for a physical, she's asked about those things, sort of like, are you depressed? Are you having chest pain? Are you having hot flashes? That would be ideal, but that doesn't usually happen. So, when she goes in for her annual physical, or if she makes a specific appointment about it, she could definitely talk to her doctor when she's been a year since her period and when she's having symptoms. In 2002, when that WHI Women's Health Initiative was stopped, and we could, you could do a whole webinar, five
Sure.
webinars
Yeah.
just on
Just
that.
like a little piece.
But they stopped it because there was a feeling, and this idea persists even today, that hormones caused breast cancer. That was the sort of feeling back then, and a bunch of other scary headlines came out back then. And they prematurely stopped it at that time because of that fear. And that fear that got put out in the news and stuff, it's just stayed even to today,
Correct.
even in the face of contradictory information, and even from the guidelines of the guidance of the people who actually participated in that study that did not agree with the guidelines that were put out. But basically, they thought there was an increased risk of breast cancer and heart disease and stroke and things like that. What So after that, and when everyone got pulled off in 2002, there's been so many more follow-up studies and actually reanalysis of the data. There were 60,000 women in that study that were put into two arms, right? So menopause hormone therapy, HRT, people also call it hormone replacement therapy, is estrogen, because our ovaries produce estrogen, and it's the low estrogen that gives us all the symptoms.
Mm-hmm.
And it's progesterone, because that's the other female hormone that they work in conjunction and regulate our cycle and stuff. So if a woman's in menopause and she's treated with hormone therapy, it's the estrogen that mainly resolves her symptoms. And if she has her uterus still, like if she's never had a hysterectomy, she also gets placed on progesterone to balance out the estrogen and to protect her uterus, just similar to the way it is before menopause. So the estrogen and the progesterone. So a reanalysis of that data back then, the data that pulled so many thousands and thousands of women off their hormones, actually they found when they looked at that data that the women who were in the Premarin arm, because Premarin is the pregnant mare urine hormone that comes from horse urine, basically distilled horse urine. That's what we got. That's what we had back then, and that's what we still use in sometimes today. But the women who were in the Premarin arm of that study, who were randomized to Premarin, they actually turned out to have decreased incidence of breast cancer, less breast cancer than the women who were given placebo, than the women who were not treated with hormone therapy. So that's a total opposite result than what most people, including me, believed from what I'd heard about that study. So reanalysis is women who were treated with Premarin alone, because those women had had hysterectomies, in hindsight, or when they followed them for many years, had a decreased risk of breast cancer. It was protective almost for breast cancer. And the women who were on the Premarin and Provera, which is the progesterone that they gave those women, it's a synthetic kind of progesterone, those women were found to have a tiny increase, a minuscule increased risk of breast cancer, and a very low relative risk of breast cancer increased incidence compared to other things in our day-to-day life that we do all the time, like A woman who drinks a glass of wine every night, or a woman who's over her ideal body weight has an increased risk of breast cancer. But that sort of fear, women have a great fear, an understandable fear of breast cancer. It's very personal, it's very sort of tangible. And that fear sort of clouded out all the detail, all the good science, and just sort of created a knee-jerk reaction. Now I think women are starting to get a little more informed and empowered, sort of to talk about it and to question, like, wait, I can't get treatment. Wait, I'm going to have to deal with this for the rest of my life. And the other thing is our lifespan has increased. So, like 100 years ago, we died around 60. And now we're going to live to be maybe 80, 90, 100, which means we will spend the second half of our lives, if we don't get hormone therapy, without hormones, and that has total implications. So yes, everything we do has risk, including aspirin, including ibuprofen, including Lipitor. Everything has a risk. Driving has a risk. But we, as educated women, as informed women, as modern women with access to a computer, we make informed decisions, and we should have the power to sort of balance that out. We should be empowered to balance those risks for ourselves and decide what is the risk and what is the benefit. So that brings me to the NAMS, which is the North American Menopause Society. So they put out a position statement this year, and they said that for a woman who is less than 10 years from her last period, or who's less than 60 years old, the benefits of hormone replacement therapy outweigh the risks. And that's huge, because that means for the majority of women who've just gone into menopause, who are suffering with symptoms, the benefits of the treatment outweighs the risk.
And we're talking about systemic, right? We're talking here
systemic hormone therapy. That's systemic hormone therapy, exactly. Yeah. Let alone vaginal estrogen, which treats the dryness, which is no risk basically for your average woman, and could easily, I know because you're a urologist, easily treat the vaginal dryness that women get. So one of the most common symptoms, hot flashes. One of the other common symptoms, vaginal dryness. And low dose vaginal estrogen can often treat a woman's vaginal dryness just alone, just a cream, a simple prescription. And sometimes they don't even get that from their doctor. And I think it's also because of that misconception. But it's so safe that in the United Kingdom, as of last month, vaginal estradiol is over the counter. Correct. That's how safe it is. Aspirin's over the counter, ibuprofen's over the counter, vaginal estrogen over the counter. That's how safe it is, and still so widely underprescribed and underused.
Well, first of all, there's so many barriers because it costs, if you get for the cream that you could put around the urethra where you pee out of the vagina. This cream, it's a pea size. It's like your fancy cream that you put in your face, expensive cream, just a little bit goes a long way. Yes. And actually it comes with an applicator. Just throw that in the trash. You do not need an applicator. You don't need to glob up your vagina full of estrogen cream. It's just a little pea size, like toothpaste amount. Open up the lips and just put it right around where you pee or the vagina. And it's really expensive many times for insurance. Even with insurance, they're paying $100, $400. But actually with the Mark Cuban's pharmacy, the cost plus, it's really about, we looked it up together, it was about $40 for the tube of cream. So you can use that pharmacy. You could also use compounding pharmacies that your physician can prescribe to, and it's much, much lower price.
Or GoodRx also.
GoodRx coupons, and then it's going to bring that. It really should be about $40 for the cream, which I know even for some people can be cost prohibitive, but the cost of a UTI or just going to urgent care, copay and the prescription, you're already paying for the whole tube. So that is really preventative. It's so important. It will, even if you're not on the systemic, and even my patients that are on systemic, many times I even put them on the cream because it's still not hitting the tissues as much as I would like it. And they still have dryness. And so we want to put that right around the urethra, and the rate of infection just plummets.
Yes.
So it's so important.
And the sensitivity of the clitoris. Talk about sensuality and the changes with the sensitivity and the perfusion of the clitoris and the protection for the urethra. So important. We care so much about our skin, and we put our eye cream and we put our face cream and we do our mask, and we just leave our vagina out to dry.
Yeah, because
we could do something for it too.
yeah, if there's not babies coming out, we just think it's not important. Like, and it's like nobody wants to look under the hood, and like even doctors, we put this drape like it's some hidden scary place, and like it's not. It's part of
Yeah.
our body. Let's
Yes.
demystify, like body parts
Yes.
that are really important. And yes, it's going to be painful to have sex if it's dry.
Yes.
You're gonna get infections because the normal moisture is not there.
Yes.
The normal flora that we call the good bacteria is no longer there.
Yeah.
And so we cannot kind of get rid of the bacteria that we all have there. It's not a sterile place. Like people are like, oh my God, why is there bacteria? We all have it. If I have a swab in my arm, there's full of bacteria, but it's not killing me. So we don't have to sterilize it.
Yeah.
But we do have to pay attention to our vaginas, even if no babies are coming out, or we're not getting anything in the vagina like a penis or other objects for sexual pleasure, but you're going to feel better.
Yes. Some of my patients, they say, oh, I don't need that. I'm not having sex anymore. They say, I don't care about sex, which is kind of to me sort of sad because they're only like 55 or 65 years old. And I haven't had sex in 5 years. Which is a whole other conversation. I mean, that's part of this conversation because that's not surprising if they're having all these changes and it's been undertreated. But I sort of gently walk them back and say, okay, but is your vagina dry when you're not? It's not like you're using the cream just so you can have sex. In fact, you don't use it when you're having sex.
Correct.
You use it when you're not having sex because you don't want to be getting estrogen on the penis and stuff. But I say it's not just so you can have sex, although that's nice too. It's so that you don't get a urinary tract infection. It's so that you don't have burning and itching. A lot of women are treated over and over again for a yeast infection because they're itching, and the doctor's like, oh, it's yeast, because when you're younger it usually is, but when you're over 55 it's probably dryness from menopause. And I think it's under-recognized, under-treated by doctors and under-recognized by patients, women, that they get so used to feeling sort of dry and burny and itchy, and they forget how good it felt to be sort of well lubricated and taken care of. And so I just sort of walk them back into it's just like cream for your face, like you said. It's self-care for your vagina. It's thanking her for everything she's done for you all these years,
Yeah, it's just like if you don't put hand cream, your knuckles get crackly and uncomfortable. It's just imagine your vagina there for like 10 years. Like it feels uncomfortable just to sit on it. And that's a great point about the itchiness. I mean, I think I'm yet to see a true yeast infection in a patient. I mean, I really don't think I've seen one. That itchiness is a dryness.
Yes.
And the burning. So many come with UTI, and like I'm gonna do my little urology hat. A UTI, urinary tract infection, is, let's just say what it is, define it: pain, frequency, urgency, and you have a urine culture that shows 100,000 colonies of bacteria. If you don't have both, that is not a UTI. That just may mean that you have frequency and you have burning, and the burning may not be from bacteria or urine infection. It's because the urine is acidic usually. It touches a tissue that is dry, raw, red. Look at it. I mean, put a mirror and look at yourself. It's raw, it's red, it's pale. So when the urine touches, of course it burns. And so it's not an infection. And so the culture is going to come back negative, but they give you antibiotics anyway that you don't need.
Yeah.
And so that's what a UTI is. And that's why
they don't know better. So they go, okay. And they're on antibiotics like every day, like prophylactic antibiotics, which have their own side effects.
Correct. And also the other flip coin to that is something called asymptomatic bacteria, a fancy name to say you have bacteria, like you went to your physical, they check your urine, and then the doctor's calling you to tell you you have a UTI. You do not have a UTI unless you have pain and burning and frequency and all this other symptom. If you feel fine, but the urine had bacteria, you have to do nothing about it. You're not going to die, I promise you. If you're pregnant or you're going to have a surgical procedure, usually urological, yes, treat it. But that's the only time you need to treat it. The rest of the time, you just live with the bacteria. You do not need to be overtreated for something that then truly will give you a yeast infection. And it's going to give you side effects and mess up your intestinal flora. So I want to make that distinction from the urologist perspective about what is a true infection, why is it burning, because not everything that burns is an infection. Most of the time in menopausal women, what burns is the dryness.
Yes. And just to piggyback off what you're saying, when it is an infection, because that happens too,
That will happen too, yes.
so many older women, 60, 70, 80, they actually wind up in the hospital with urosepsis, because they can go from a little UTI to full-blown infection because their lower immune system. And if we think about if women wind up hospitalized and in the ICU with sepsis that starts from a bladder infection to a kidney infection, and if those women had been treated with low dose vaginal estrogen, something so simple and so safe and so easy for a doctor to prescribe, so simple for a woman to use, it could prevent, her hospitalization, her infection, her need for antibiotics, and all of that too. So I think as a just as a huge one easy simple message, low dose vaginal estrogen is safe and women should be able to get that from their doctors. But the sad thing is, even now, even just that, even with all that knowledge out there, women are undertreated for that too. So that's why I'm so happy you brought me here to talk about it. And I know you educate your patients, and I know you're putting the word out, and some other doctors are out there putting the word. And if anyone takes nothing else from this talk about dancing feminine flame, this girl's on fire, but vaginal estrogen safety and how it can be used and how it can be a game changer for vulva and vagina and urethra and bladders, and sex life, so important because we have to take care of our vulva and our urethra for the rest of our lives. This baby's got to last us a long time.
It is safe. Yeah, just like Christina's saying, vaginal estrogen is safe. There's so many positions, and it's just a little bit goes a long way. Just think about it as your cream. The problem though is this label. When you go home after you spend $100 on this cream, you get home and you read the label. The label is draconian or archaic, has not been changed, and it says that you're going to get breast, uterine, ovarian cancer, all kinds of cancer. You're going to die. And that's just not true. And of course, if I saw that, I'm like, I'm not touching that. Why are you going to give me that?
So we have to tell them.
And I tell them ahead of time. I tell them before they get the label and they start getting panicky and anxiety attacks, because I also use in the Academy of, they call it the Cancer, academies. They also have their blessing to use it. It's a conversation we have to have. But I do have many women with cancer that we still use it because the quality of life is so important. And when you've been treated for breast cancer and you've been on those hormones, tamoxifen and all that, that depleted all of your estrogen to cure cancer. Yes, that's very important. But then you're so miserable. It's so painful.
Yeah.
You haven't had sex in decades because of course you cannot, it's impossible. No. But you're getting so many infections that hurts all the time and you're miserable.
And so talk about your sensuality being impacted.
You have no sensuality. You're just like,
the treatment for breast cancer puts you in menopause. Yeah. Now your vagina's dry.
Hurts.
You've had cancer. You can't have sex. It's like, we got to treat the whole woman. Yes, we have to protect us from cancer. And yes, but here's the deal. I did want to say this, really important. So vaginal estrogen is safe. That's number one. Vaginal estrogen is safe. But the other thing I wanted to say is, that controversy around the hormones is that women who, this is kind of wild, but women who take menopause hormone therapy, HRT, estrogen, progesterone, live longer lives than women who don't. All things being equal, all risks taken into balance, women who are treated with hormone replacement therapy, I know we're technically not supposed to call it that. We're supposed to call it MHT, menopause hormone therapy. Basically, hormone replacement therapy, women who are treated with estrogen and progesterone, on average, all comers, live 3 years longer than our sisters who do not. Yeah. And nobody talks about that. And this one more step, a woman, and also has a decreased chance of dying from breast cancer, which nobody talks about. They talked about that minuscule increased risk with the progesterone arm, but that was increased risk of getting it. It wasn't increased risk of dying from it. So paradoxically, or just women who take menopause hormone therapy live longer, but on average 3 years longer than women who don't, which nobody talks about that, and are less likely to die of breast cancer than women who don't. Because the number one killer of women, I know you know, but I'm a family doctor, is heart disease. Heart disease. Women are 7 times more likely to die from heart disease than breast cancer, but there's just this innate fear in us of breast cancer. And I understand it. I've had family members pass from breast cancer, so I get it. But we can't let fear of one thing stop us from treatment and relief and longevity,
Of course.
overall longevity. It's so, it's
It's
sort of like highway robbery of women to be scared out of a treatment, which number one treats our symptoms, but number two, where for many of us, especially the ones treated early, where the risks are greatly outweighed by the benefits of menopause hormone therapy: less osteoporosis, less hip fractures, less dying from breast cancer, 3 years extra from life, and so many more, less hospitalizations from UTI, and all of that. There's just so many. And especially nowadays, the formulations for HRT, instead of, horse urine hormones and sort of older synthetic progesterones, now we have estradiol, which is like chemically identical to what's produced in our ovaries before menopause, and micronized progesterone, which is identical to the progesterone that's produced in our own ovaries for before menopause. And what the newer research is showing, and what they're going to talk about this year in NAMS, is newer studies are showing that the micronized, which is bioidentical, which is a loaded term, but it was identical to the body's progesterone, has not been showing that even that minuscule risk of breast cancer incidence, not death. But let's just say worst case scenario, that there is that minuscule risk, which is less than the risk of obesity or less than the risk of a nightly glass of wine. A woman has the right to make the decision of what risk she's willing to undertake for what benefit: sex life, strong bones, good skin, strong bladder, longevity. And I think we need to get the message out, because we all deserve that. And I sort of suffered through figuring it out, suffered talking to my colleagues trying to figure it out. And I was like, okay, I got it. I feel good. I'm making a decision. And NAM says it's good. It's good. All right. But then I thought to myself,
what about everybody else?
It's not right if I'm the only one that's knowing it, or if my sisters and friends and cousins and colleagues don't know, and there's still this shroud of fear. It's just, I don't want to go there alone. I want to enjoy it with all my sisters, my physician sisters, my family sisters, my friends. I think we all have a right to be informed and make that decision. Because if we can make an informed decision, like whether we want to have children, whether we want to have fertility, whether we want to have a family and be married, we are smart enough, all of us, to make the decision about how we want to live the second half of our life. It's not like we only have value until we stop having babies and then we're not fertile, so go shrink away with your dry vagina. No, it gets even better if we continue to take care of ourselves. We can stay. That's why I say, girl on fire. Fire because of hot flash, sure, okay, but fire because our sensuality and our wisdom and our confidence can maintain until the very end. And I mean the very end. A woman who takes care of her body and her pelvis and her vagina and her urethra, she can stay feminine, she can stay sexy, she can stay sensual all those years. We don't have to sort of be just dry up and go shrivel away and hide out. I'm not going down that way. And I don't want my friends to go down that way,
No, it's true. I mean, because we think like, oh yeah, you're just like, what's your use now? Now you just like, you had the babies, they're out of the house, like go read your book and like crochet.
Do a crossword puzzle and crochet.
Yeah. And like, that's not what it's about. It's about like, and of course it makes, I don't have to be a physician to know like you're going to live long because you're happier, you're not depressed, you're out and about because you have energy to go do the stuff and hang out with your friends and do things that you're going to live longer when there's connection and when they're, you're with other people because you have the energy to do so. But if you're just like depressed and like, oh yeah, nobody's going to live longer that way. You want to die and you will die because you're miserable.
Yes.
So important to take care of you, to know that it's safe, both the systemic and so much the cream. If you don't even want to do the systemic, do bare the cream. Minimum. Do bare the cream. Minimum. I have done this for 15 years. I've never seen anything bad happen from it, except that you can't purchase it. But now there's options that are cheaper.
Yes.
Some people do get a little bit more like burning with a Premarin initially. So I switched them to estrace, and it's a little bit less sometimes. But it's so safe. And
and also they can get a little bit of burning when they first start. Like say
it's so dry.
And you have a rash and it's all cracking. Yeah, you need to put hydration on it, but it can burn in the beginning, but you got to keep using it because you got to build up that layer of skin and lubrication and nerve. So they might have to push back that beginning burning. Some women are like, "Ooh, it burns," and I'm like, "Yeah, I know it does because it's
Yeah.
been so neglected." But if you stick with it, it's going to get better, and it does get better. It does get better.
Tell people about, now you started, maybe you have convinced some people that this is safe, and I hope we do. If you get anything out of this, this is safe, and both the cream and the systemic. And how long do people, because people ask me all the time, my patients, like, how long do I have to use that? So what do you tell them once you do start treatment? When do you stop? Do you stop ever?
So I want to qualify what we just said about safe. So we said vaginal estrogen for most women, almost all women,
Yes,
is safe.
almost yes.
There's a couple women who isn't, and that would be if you're actively having breast cancer, like right now, it's not treated, but you're having breast cancer, you would have to talk that over with your
Correct.
oncologist. Another woman it would not be safe for is if you have like vaginal bleeding and you're menopausal and you don't know why, and you got to get that sorted out. So those are just, I think, just maybe two that need to talk to their doctor and get sorted out first. So that's vaginal. Most women, 99.9% of women can take it and should use it. And then for the systemic hormone therapy, estrogen blanket, for the most part, most women can take it. And according to NAMS, if it's been less than 10 years since your last period, because some women go into it earlier, say 40, and so like 60 would be 60 for 10 years for someone who went into menopause at 50. But if it's been less than 10 years since your final period, the risks are outweighed by the benefits. If you're over 60 or you're over 10 years since your last period, because there's some women like that too, they haven't sought out help and now they're having their vaginal dryness. For those women, the risks are greater than for the younger women. And that was part of that women's health initiative. One of the problems with that study is the women they enrolled, the average age was 62. The women were already beyond that 10-year window of safety. And so those changes that happen to our body, the dementia, the brain fog, the memory loss, the heart disease that happens from lack of estrogen, they had already started to undergo those changes. So I don't want to say it was too late for them, but so much had already happened to their body. So if a woman is listening to this and she's over 10 years out, it's not so straightforward safe. It doesn't mean it's impossible. It just means that she even has to even more carefully weigh her risks. Not impossible, but there's a little more risk. So under less than 10 years out, risk usually outweighed by the benefit for most women, unless she has a personal history of breast cancer or a personal history of leg clots or a personal history of stroke, a personal history of heart disease. Those things she would need to talk to her doctor about. But I'm just talking about without the nuance, a healthy woman less than 10 years out, the risks are outweighed by the benefits. So when should she start? If she's 50 and she's symptomatic, kind of like the earlier the better, before those changes start to happen to the vagina and the urethra and the bladder and all of that.
So
Yeah,
definitely
and
like
how
before
long
the
should she
10
stay
years
on
is the last period, right? Like in that window. I mean, if you are symptomatic, like which you
within
will
that
be. I
10-year
mean,
window?
I don't really know anyone that is not symptomatic. We
That's
just
right,
don't talk
especially
about
if
it,
you
but
consider
they are.
Yeah, especially if
um,
you consider all the symptoms,
yeah,
not just the
correct.
hot flashes, but the insomnia. So if you think about it, if you can't sleep at night, and women who are hot flashing and sweating all night, they cannot sleep
Terrible.
all night. I know that was my big problem, and I thought, oh, I'm just stressed out. I can't sleep anymore. I wake up at 2 a.m. I'm just stressed out because I didn't know insomnia was a symptom of menopause. But if you can't sleep at night, you're tired during the day, you're moody, you're not performing at the top of your game, you're irritable with your family, you get depressed and anxious. I mean, it's just like a whole domino effect of how it can impact your life. So when we talk about symptoms, who should be treated, we have to think about those less well recognized symptoms and how long a woman should take on it. So they used to say a woman should be on the lowest dose possible for the least amount of time,
Okay.
period. And they used to say she should probably be taken off once 10 years have gone by. So now the NAMS guidelines are saying a woman can stay on it unless there's a reason why she shouldn't be on it. Something comes up in her health that's compelling. A woman can stay on it if she's still symptomatic, if she's still getting a benefit, unless a contraindication to being on it comes up.
Perfect.
And this is a huge change from how it was before. Least amount, less amount of time. Like you can give them a taste of it, but then rip it out of their hands as soon as they've gotten some of it. It's not, that's not the guideline anymore. So of course as we age, we get, diabetes, we get hypertension, all kinds of stuff comes up, and we have to sort of weigh, maybe on an annual basis, weigh out that risk and benefit with our doctor. But for most women, unless a huge contraindication comes up, and now that we know they'll have longer longevity and better mortality outcomes. I think that things are changing.
That's fantastic. I mean, that's great news. And, I don't really do the systemic, but I definitely do the vaginal as a urologist. But, it's so important to like learn that and know that, because they do ask me like, what should I do? And of course, then they're like, go see your gynecologist or your family medicine. I mean, I can, hopefully now with this really say, well, actually, this is a data, and like, I can look it up more. And, even for family members, so important. So, I mean, I really love that. And I think we kind of went through, the three main important things, but what kind of three takeaways of all this, because I think we only can remember three in our brain, especially if you're in menopause and you're brain foggy, you probably remember one. But
And I get so excited. Like, I get so excited. Like, I've spent like hundreds of hours deep diving on all this in books and podcasts and everything, webinars and everything I get my hands on. So I sort of wish I could just sort of like download it all into every patient and every woman and every friend.
you will.
But I would say I wish, because I want to ride this journey together with all of us in a beautiful way. But I would say take homes are: there's more to menopause than a hot flash.
Correct.
A hot flash is it's kind of beautiful if you think about it.
Signal.
This,
Yeah,
this body, this beautiful, wise woman's body gave us a hot flash so that we could have a signal like, whoo, oh, I think I'm in menopause. I mean, it's brilliant. Actually, it's beautiful, because then we could like get the wake up call. But there's the more subtle, the insomnia, the chronic fatigue. So the first takeaway is there's more to menopause than a hot flash. There's a lot of symptoms and a lot of changes that happen, and we can, with just a little bit of investment of time, learn about them. And I talk about these on my website, feminineflamemd.com. I have downloadable videos, and one is all the symptoms, the menopause checklist, and all the symptoms that would surprise you about menopause. And the second takeaway is, so one, there's more than a hot flash to menopause. Second takeaway, for most women, I would say 99% of women, low dose topical vaginal estrogen is safe and life-changing.
Absolutely.
For our vulva and our vagina and our bladder. Life-changing.
Stand by the urologist too. Boom, boom. I agree.
Dr. Diana Londoño.
I agree. That's 100%. Yes, life-changing.
Excited about vulvas everywhere.
Yeah, life-changing. It really is. People come back like, oh, and like, no UTIs. I mean, like, who wants to be in antibiotics all the time? It's awful. I mean, it's just terrible. So
messes up your
vaginal
flora, your gut flora. So one, there's more than a hot flash. Two, vaginal estrogen is safe for most women. And three, don't let your doctor or your friends scare you away from HRT, menopausal hormone therapy, if you need it. It's not that complicated to figure out. Like we said, less than 10 years out, benefits outweigh the risk. It's not that complicated, but I think the problem is many women have been shooed away, kind of brushed aside, like, you're okay. And the doctors will give other prescriptions like, oh, take some clonidine, take an antidepressant, take some gabapentin, other prescription medications that, by the way, also have risks. All medications have risks, but women kind of get brushed aside, like, yeah, you'll be all right. You can deal with it. You don't want to die, do you? You have breast cancer.
But that's also just treating the symptom and not the cause. So I mean, I think that's important to say. Yeah, you're putting all these band-aids for the symptoms, for like the palpitations and this and that. That's good too, I'm sure. But like, why take 5 meds when you can take one that's going to take care of the whole problem? So I didn't want to wrap, but I wanted to say, like, treat the cause, not all these symptoms and put out fires. Like, really treat the cause. So I just wanted to, remind people that why would you take 5 meds that do have side effects? Also, take one that's going to take care of really the source of the problem.
And they don't improve your mortality, and they don't improve your vagina, and they don't improve your mood, and they don't improve your sleep, so they don't have the great benefits. And along those lines, I know that myself, luckily I have a beautiful, wonderful doctor who has been treating women with hormone therapy for menopause before all this new, sort of reinterpretation of the data came out. She's been doing it all along since the 90s, a wonderful local doctor, Martha Gonzalez, in my town. I'm so fortunate to have found her, but I know for a lot of my sisters out there, a lot of my patients out there, a lot of my friends and family out there, their doctors, unfortunately, like me before, are under-informed, under-prepared to treat menopause. So we sort of have to be very proactive. So one, we can't be scared away and kind of made to be afraid. We have to get informed. We have to take time to get informed. We have to. We have to learn about other stuff. We got to learn about this, and then we have to keep talking to our doctors until we get taken care of. And if our current doctor can't do it, then we have to find one that can, whether it's an endocrinologist, whether it's an OBGYN, whether it's a family doctor who's taken an interest and a passion for it. The North Atlantic Menopause Society has a list of doctors who are certified, but there's more doctors than just those that can treat it. Many endocrinologists, many OBGYNs, and many family and internal doctors who have taken an interest and a passion in it. And I'm hoping that we're creating this tsunami of excitement about vulvas like you, like a tsunami of change, so that women don't have to suffer anymore. We do not have to suffer. We can get treatment at the very minimum with the vaginal estrogen, at the very maximum with systemic hormone therapy. We have to find a doctor who can treat us. We have to find a doctor who's not afraid to treat us and who's informed, because it shouldn't be scary with the new data, the new reanalysis of the data. The research is looking good. It's looking better every year.
Yeah, I love that. So important. And yeah, be proactive, stay informed, self-advocate, like Dr. Dewey says, so important, whether it's your vagina or whether it's anything else. Ask questions. I mean, even as physicians, just ask, like, why are we doing this? Or like, what if, like, what if? That's a great question to ask. Or like, why not?
Why not?
Yeah.
Why not? Oh, you could get breast cancer. Really? What's my risk exactly?
Yeah. Yeah.
What's my risk of that medication you're giving me as an alternative? You know?
So we have a few minutes. I'm definitely, going to tell where everybody can find you. So I know you mentioned a little bit your new website, which is absolutely beautiful. And there's some videos you can download and some guides to kind of get you in this path. So it's a beautiful website. Please tell them how to find you with your website. What is it?
Thank you. So the website is feminineflamemd.com. For the downloadable videos, I'm going to be having a digital course come out by the end of the year, so a woman can, beginning to end, A to Z, get all the information that she needs. On Instagram, Feminine Flame MD, I make little short, informative videos and some feminine inspiration and dance, just to make this let's make this ride joyful. It doesn't have to be so serious and so scary. We should have fun. If we're not having fun, like, what are we doing?
Yeah, exactly. No, that's what I love about you. I just love, like I said, you ignite the passion into other women and other people to be authentic and be unapologetic of just your sensuality, your femininity, which is so beautiful, so palpable. And that's really how I found you, and I was like, who is this woman, and the volcano, just like living life and moving and dancing. And I want whatever she's taking because I'm going to be there pretty soon. Apparently,
HRT.
Apparently in 3 years, I'm going to be there. So I need to know what to do when it's coming. And, I'm feeling down or, dry and hot and sweaty and I can't sleep. So I need to know what to do. So this has been so helpful. So yes, please follow her on her website or Instagram, also in LinkedIn, just to connect with her and, learn more about this, spread the word. This will be recorded like it is, and it'll be the playback at physiciancoachsupport.com. You can see this one and all our previous ones with different topics. Next month, we will be talking about the 5 habits of positivity with Dr. Onika Williams, a urologist. So if you want to talk about mindset and thoughts and like how can we stay positive and have a growth mindset, this is going to be absolutely fantastic episode next month. I'm really looking forward to that. So thank you again for everybody here. I really appreciate you being here, learning, getting excited, getting involved, and really reclaiming your flame and your sensuality, your excitement for life. So thank you,
everybody. You so much. I'm so blessed to know you, soul sister, and thank you for the work you do for the healers that need healing. I mean, that's such important work, because if we are burnt out and can't do it, then we can't serve our community and our patients. So thank you for your beautiful work, your beautiful soul, and for this beautiful opportunity. Mwah. This girl is